It's time for the 3-question one for Renal 7. Let's get going. What nerve runs with the following arteries? So first we have the anterior interosseous artery. That goes along with the anterior interosseous nerve. Next we have the posterior interosseous artery. It goes along with the deep branch of the radial nerve. Next we have the posterior circumflex artery. That's going to run with your axillary nerve. Next, the suprascapular artery is going to run with your suprascapular nerve. The thoracodorsal artery is going to run with your thoracodorsal nerve. The deep brachial artery is going to run with the radial nerve. The dorsal scapular artery, the dorsal scapular nerve is going to run with that one. The lateral thoracic artery runs with the long thoracic nerve. The ulnar artery runs with the ulnar nerve. And the brachial artery runs with the median nerve. Next question, what CSF changes are present in Guillain-Barré syndrome? So there will be a normal cell count, but you're going to have an increased protein in the CSF. So this actually has a special name. It's called albuminocytologic dissociation. So you might need to look for that terminology when it's being used in CSF findings with Guillain-Barré. Next question, what can cause a rash on the palms and soles? So first think about secondary syphilis. Also think about Rocky Mountain spotted fever and also Coxsackie-A virus. And then one more would be Kawasaki disease, which can cause a lot of disquamation as well. All right, that brings us to the end of the warm-up. Let's get to that lecture now.
In this video, we're going to talk about some diseases of the kidney, specifically diseases of the glomeruli. Now, Dr. Lewis is going to talk about kidney stones and kidney cysts and kidney tumors in the next video. But in this video, we're focusing on diseases of the glomeruli, like nephrosis and nephritis. Now, being able to recognize the various nephritic and nephrotic syndromes is definitely a 4 or 5-star topic. You are going to see these on your test. It's one of those topics that a lot of students tend to automatically tune out and say, this is too hard, this is too confusing, I'm not even going to bother learning this. Or you hear the word glomerulonephritis and then you start having a panic attack. So I know this is confusing because there are a bunch of diseases and they have similar sounding names and there's a lot of overlap between them. I don't want you to panic. I don't want you to freak out or give up hope. This really is pretty manageable. I'm going to help you understand this. So let's start with some basic terminology. The first thing to recognize is that nephritis and nephrosis, or nephritic syndromes and nephrotic syndromes, are descriptions of the clinical presentation. They don't necessarily tell you anything about what's causing that clinical picture. So the big difference between a nephritic syndrome and a nephrotic syndrome is how much protein is found in the urine. We're going to get into more detail on that later, but for right now, when you hear nephrosis or nephrotic, I want you to think big-time proteinuria. Nephrosis means there's more than 3.5 grams of protein in the urine per day. That's a cutoff worth knowing. Proteinuria of more than 3.5 grams per day is nephrosis. Now, informally, we may call that heavy proteinuria. So anything above 3.5 grams per day is heavy proteinuria. Anything below 3.5 grams per day is called light proteinuria. Now, patients with nephritis will often have some proteinuria also, but it's usually less than that 3.5 gram cutoff. There are some types of glomerulonephritis that present with more than 3.5 grams per day. We might say they have nephrotic range proteinuria, but we could still call it nephritis. There are some other features that distinguish nephrosis from nephritis, and we're going to cover those in a little bit. But in general, just remember that more than 3.5 grams of protein per day is nephrotic, less than 3.5 grams of proteinuria is nephritic. Now, there are also a handful of terms we use to further characterize these glomerular diseases, based not on the clinical presentation, but based on what we see under the microscope on biopsy. Now, we're going to look at some microscope slides in a bit because that's really important for step 1. But the vast majority of patients with kidney disease don't actually get kidney biopsies. In practice, it's a lot more common to focus on the clinical presentation. But when we look at the kidney biopsy, we see that less than half of the glomeruli are affected. We call that focal disease. And if more than half the glomeruli are affected, we call it diffuse. So that's why some diseases are called focal segmental glomerulosclerosis and others are called diffuse proliferative glomerulonephritis. It's just describing what we see on the biopsy. And even that's sort of a rough estimate. It's not like you have to count them all up exactly. But if most of the glomeruli are affected, that's diffuse. If it's only affecting the glomeruli here and there, it's focal. When you look at the biopsy and you see that the basement membrane is thickened, that's called membranous, like membranous nephropathy. And if you have proliferation of cells, that's called a proliferative disease. So diffuse proliferative glomerulonephritis means that the glomeruli are hypercellular, you have proliferation, and that more than half the glomeruli are affected. That's why it's diffuse. And then membranoproliferative glomerulonephritis means that there's both thickening of the basement membrane and proliferation of cells. It's membranoproliferative. You may also hear these diseases referred to as being primary or secondary glomerular diseases. That just tells you whether this is a purely kidney disease, which is primary, or something that's more generalized and more systemic. For instance, patients with lupus and lupus nephritis are said to have a secondary renal disease because the primary problem is lupus. But ultimately, the patterns we see on biopsy can often be attributed to a bunch of different primary disorders. For example, MPGN, or that membranoproliferative glomerulonephritis, can be due to hepatitis B, hepatitis C, lupus, rheumatoid arthritis, monoclonal gammopathies, and so on. So the pattern you see on biopsy isn't necessarily a diagnosis in and of itself. So let's dive in and look at some details about these different diseases, starting with the nephritic syndromes. So itis means inflammation, so glomerulonephritis means inflammation of the glomeruli. So interstitial nephritis is covered in another video, and that's inflammation of the interstitial tissue. Pyelonephritis means inflammation and infection of the renal pelvis and the renal parenchyma. But glomerulonephritis means there's inflammation of the glomeruli. Now, with glomerulonephritis, we already said there might be some light proteinuria, but the big thing clinically that I want you to think about is hematuria. Not necessarily, frankly, bloody urine, although that's possible, maybe just some reddish urine, maybe brownish urine. And you're going to see red cells when you examine the urine microscopically. And with that, you'll often see red blood cell casts in the urine. So Dr. Lewis is going to talk more about urinary casts in the next video. But if you have inflammation of the glomeruli, there's likely to be blood in the urine and then red cell casts. You'll often see a decline in renal function with nephritis. You'll see azotemia. So azotemia means that the serum BUN and creatinine are elevated. And then when the kidneys aren't working, you'll often see some hypertension because of salt and water retention and expanded intravascular volume. And there may be decreased urine volume, which we call oliguria. And obviously some of these diseases can progress to full-blown renal failure, and that may even cause anuria when the patient doesn't make any urine. So the first type of nephritis I want to discuss is post-streptococcal glomerulonephritis, which is definitely one of the higher yield ones. Now, as you might guess, this is a sequela of streptococcal infection, specific strains of group A strep. You're going to see this in a patient who had strep throat or a group A strep skin infection like impetigo 1 to 3 weeks prior to presenting with glomerulonephritis. So this is a type 3 hypersensitivity reaction where circulating antibodies bind to certain streptococcal antigens and they form immune complexes, and those immune complexes get deposited in the glomerulus. But it's worth mentioning that because this is an immune complex mediated disease, treating strep throat with antibiotics does not prevent post-strep glomerulonephritis. Antibiotics do prevent acute rheumatic fever and they prevent rheumatic heart disease, but they do not prevent post-strep glomerulonephritis. Now, post-strep glomerulonephritis is more common in children. So think about it. Who gets strep throat most commonly? Little kids. And one thing that's not very specific, but it's a helpful association, is that these patients will often have brown urine from heme pigments in the urine and from the hematuria. So again, hematuria doesn't have to cause red, frankly bloody urine. It can just cause some brown urine, tea-colored urine, or sometimes it's called Coca-Cola urine. So we often see that with post-strep glomerulonephritis. So if they give you a child who presents with a history of strep infection or a history of an upper respiratory infection a few weeks before, and now he's got brown urine, think about post-infectious or post-streptococcal glomerulonephritis. Now, if you get a renal biopsy, which again, we usually don't get a renal biopsy in these patients because the history is pretty obvious, but if you did get a biopsy, you might see hypercellular glomeruli, so this is a proliferative process, right? There's going to be lots of neutrophils in the glomeruli. Immunofluorescence will show lumpy, bumpy deposits of those IgG and IgM immune complexes, and also complement C3 that get deposited in the mesangium and they get deposited along the basement membrane. So these deposits are usually called subepithelial humps. You can usually see them better on the electron microscope. So let me walk you through this on a drawing and then we'll look at the real deal. This is a drawing of a normal glomerulus. And I want to start by orienting you to the different parts so that when we look at the abnormal ones, you know what you're looking at. These pinkish red cells are the endothelial cells of the glomerular capillaries, which have fenestrations that allow plasma to be filtered. The purplish cells are the epithelial cells with podocyte foot processes, nice uniform foot processes. This smooth green line is the basement membrane, which is sandwiched between the pinkish red endothelial cell and the purplish podocyte foot processes. Remember, those are the three layers that make up the glomerular filtration barrier: the endothelial cell, the negatively charged basement membrane, and the podocyte foot processes from the epithelial cells. Now this light brown region is the mesangium, or the mesangial matrix. And the darker brown cells inside the mesangium are the mesangial cells. So now let's walk through those changes we just listed for post-streptococcal glomerulonephritis. You see these subepithelial humps, these lumpy, bumpy immune complex deposits on the top of the basement membrane, right underneath the epithelial podocyte foot processes. And that's the key feature I want you to remember about the microscopic appearance of post-streptococcal glomerulonephritis. Lumpy, bumpy deposits, these subepithelial humps. We also have hypercellular glomeruli, so lots more mesangial cells than normal, and also some neutrophils within the glomeruli. Now, here's the real deal. This is a light micrograph, and all you can really make out here is the hypercellular mesangium, and there's some neutrophils in here. There's so many cells that you can't even really make out the capillaries distinctly, but you don't really see those lumpy, bumpy deposits on light microscopy. So here's the electron micrograph of a patient with post-streptococcal glomerulonephritis, and you can see these dark subepithelial humps kind of all over the place. It's not really very subtle if you know what they look like. And then again, you have a hypercellular mesangium, and the lumen of the capillaries are kind of compressed. So the L is marking the capillary lumen. A couple of other clinical points. These patients have activation of complement, which leads to destruction of the basement membrane. And this means that there's an overall decrease in complement C3 levels. And then one test that's traditionally been used to prove that the patient did in fact have a recent strep infection is a high anti-streptolysin O titer, or ASO titer. And that's fine for strep pharyngitis or strep throat. But patients with strep impetigo may not have an elevated ASO titer. It's typically not elevated in impetigo. But there's an antibody called anti-DNase B that is elevated both in strep throat and strep skin infections. So that may be worth knowing, anti-DNase B. Next, I want to talk about IgA nephropathy, or Berger disease. Now remember, this is not the same Berger disease as the vasculitis called Berger disease that we talked about in cardiology that affects young male smokers. This is a different Berger disease. This is B-E-R-G-E-R, Berger disease. Now, a minute ago we had Coca-Cola urine, now we've got Berger disease. The next disease is glomerulonephritis. That's a combo meal, we're going to call it a day. Now, IgA nephropathy is associated with a form of vasculitis called Henoch-Schönlein purpura, which causes a tetrad of palpable purpura on the buttocks and the legs, plus arthralgias, abdominal pain from intestinal hemorrhage, and renal disease. So you remember that? So the renal disease with HSP was IgA nephropathy. Now with IgA nephropathy, patients get increased serum IgA, and then IgA immune complexes get deposited in the mesangium. And they also have a proliferation of mesangial cells. On the electron micrograph, you can see these dark, dense deposits in the mesangium down here in the corner. This huge black blob is a red cell in the capillary, but these dense deposits in the mesangium are deposits of the immune complexes. IgA nephropathy typically presents with hematuria. When you examine the urine, you're going to see those red cell casts. And it often flares up after an infection like a URI, and we also saw that with Henoch-Schönlein purpura. Next, let's talk about Alport syndrome. We mentioned Alport syndrome at the very beginning of the course in Foundations when we were talking about collagen synthesis. So Alport syndrome is due to a defect in type 4 collagen. So where do we find type 4 collagen? Strong, slippery, bloody BM. In the BM, in the basement membrane. So when you look at the basement membrane and the glomeruli, you're going to see that the basement membranes thin out, then they split longitudinally. It's kind of hard to make it out on this electron micrograph, but just remember splitting of the basement membrane. And if you remember, in Foundations when we talked about this, we used the mnemonic can't see, can't pee, can't hear, high C, because Alport syndrome causes a triad of eye problems like cataracts and lenticonus. It causes nephritis and splitting of the basement membrane, and then deafness or high frequency hearing loss. So can't see, can't pee, can't hear, high C. Now let's talk about rapidly progressive glomerulonephritis, or RPGN. These patients deteriorate fairly quickly and they progress rapidly to renal failure. That's why it's called rapidly progressive, because they get sick and all of a sudden they got renal failure. Now this is also sometimes called crescentic glomerulonephritis. Again, these diseases are sometimes categorized by how they look histologically. So what do you think you're going to see on a histology of a patient with crescentic glomerulonephritis? Well, you're going to see crescent-shaped deposits in the glomeruli made up of fibrin and complement and cells and cellular debris. But there are several diseases that can cause this histological appearance. One disease is Goodpasture syndrome, which we've talked about before. Goodpasture syndrome is a form of type 2 hypersensitivity where you have antibodies against the glomerular basement membrane. So on immunofluorescence, you're going to see a linear pattern where the antibodies sort of follow the outlines of the basement membranes. We've also mentioned that Goodpasture is one of two diseases that attacks both the kidneys and the lungs. So if you see a patient with nephritis and hematuria plus hemoptysis where they're coughing up blood, think about Goodpasture. Another disease that attacks the kidneys plus the lungs is granulomatosis with polyangiitis, or GPA, which used to be called Wegener's granulomatosis. And it also causes this rapidly progressive or crescentic glomerulonephritis. And we talked about GPA with the vasculitides and cardiovascular as well. This was one of the ones that affects the kidneys and the lungs and the upper airway, like the sinuses and the hard palate. And we said that one of the classic features of GPA is a positive C ANCA, or PR3 ANCA. That's a big clue for GPA. A third disease that causes RPGN is something called microscopic polyangiitis, which is associated with a P ANCA, or MPO ANCA. And then lupus, which can cause lots of different patterns of nephritis, can certainly cause RPGN and this crescentic glomerulonephritis. Now that brings us to diffuse proliferative glomerulonephritis, which is the most common, most severe form of lupus nephritis. Again, diffuse just means that more than half of the glomeruli are involved, and proliferative means that the cells are proliferating. Now we've said before that anti-double-stranded DNA antibodies are associated with lupus nephritis, and that's what you see here both in the mesangium and also subendothelially, between the endothelium and the basement membrane. And because these deposits kind of line the basement membrane on light microscopy, this can make the basement membranes look really dense and pronounced, which is sometimes called a wire loop appearance. So I want you to remember the phrase wire lupus, which is the wire loop appearance commonly seen in lupus nephritis. And I'll just mention in passing that diffuse proliferative glomerulonephritis can present with a nephrotic syndrome-like picture. It's not always nephritic. They may have a lot of heavy proteinuria with this. Now we're ready to switch gears and talk about nephrotic syndromes. So we said that the key feature of nephritis is inflammation, and you see hematuria with that. And the key feature of nephrosis is heavy proteinuria. Now, how much proteinuria? What's the cutoff? More than 3.5 grams per day. And you measure that by collecting the urine for a full 24 hours. That's called a 24-hour urine collection. Now the other key features of nephrotic syndrome are hypoalbuminemia, because they're spilling out a lot of the albumin out of the blood into the urine. They get edema, because they have lost most of the albumin that provides all the oncotic pressure to keep fluid inside the vasculature. So fluid's weeping out and they're getting edema. They also have increased risk of infection because they're losing immunoglobulins in the urine. They have increased risk of thrombosis because they're losing an anticoagulant protein called antithrombin in their urine, so they tend to clot. They also have hyperlipidemia because when the oncotic pressure starts to fall, it stimulates the liver to make more lipoprotein particles. Now, we don't really know why or how exactly this works, but you can imagine the liver wants to raise that oncotic pressure by any means available, so it tries putting more cholesterol into the blood. And somehow, nephrotic syndrome impairs the body's ability to metabolize triglycerides and get them out of the blood. So even though heavy proteinuria is the most important diagnostic feature of nephrosis, there's this whole constellation of findings that is also found, which is why it's called nephrotic syndrome. It's a syndrome of lots of different findings. Now, the first disease I want to discuss that causes nephrotic syndrome is called minimal change disease. Now, it's called minimal change disease because the patient looks pretty sick clinically with all this edema and proteinuria, but then when you do the kidney biopsy looks pretty normal. You may see a little bit of flattening or effacement of the podocyte foot processes, but in general, you're not going to see much on the renal biopsy because this is minimal change disease. The changes you see are minimal. Now, on our drawing, everything looks pretty normal, except for some distortion and irregularity of the foot processes. Now, this distortion makes the glomerular filtration barrier more permeable to albumin, which is what leads to the proteinuria. Now, you should associate minimal change disease with children. It's by far the most common cause of nephrotic syndrome in children. Something like 75% of children with nephrotic syndrome have minimal change disease. Now, not a lot of children get minimal change disease, but if you see a young child with nephrosis, it's most likely going to be minimal change disease. Now, this can be triggered by infections or triggered by immunizations, but we don't really know why. It may have to do with the body generating some circulating immune factors. And we treat minimal change disease with corticosteroids. More than 90% of these kids will respond to steroids, so we usually give steroids empirically without getting a biopsy if they fit the clinical picture. So if minimal change disease is the most common cause of nephrosis in children, what's the most common cause of nephrosis in adults? Well, that's a harder question to answer, believe it or not, but in the U.S., I believe it's a disease called focal segmental glomerulosclerosis, or FSGS. Now, it used to be that membranous nephropathy was much more common. We're going to talk about that one next. But sometime in the 80s or early 90s, there was a shift toward more FSGS. Now, FSGS is definitely more prevalent in African Americans and also Latinos. And you might say, well, the U.S. has become more diverse and less predominantly white, and there's a higher percentage of the population that's black or Hispanic, so of course FSGS is going to become more common overall. But that's not the whole story, because even in whites, there's been like a 13-fold increase in FSGS. So I don't know how important it is, but I always have students asking me to clarify this, and First Aid says one thing in the 2012 edition, and another thing in the 2013 edition, and yet another in the 2014. Now, I honestly doubt you're going to be asked what's the most common cause of nephrotic syndrome in adults. But be aware that FSGS is definitely up there, especially among blacks and Latinos. And the other group that gets a lot of FSGS is HIV patients. So definitely know that one. So if they give you an HIV positive patient with nephrotic syndrome, think about FSGS. Now, what are you going to see on biopsy? Well, you're going to see sclerosis that is focal and segmental. It's focal segmental glomerulosclerosis. The name kind of gives it away. So the sclerosis is focal, which means it affects less than half the glomeruli, and it's segmental, which means that certain segments or regions of the kidney are more likely to be affected than others. For instance, deeper glomeruli closer to the medulla may be affected first, and then the glomeruli near the cortex may be spared, so it's segmental. There are also variants of FSGS where only one part of the glomerulus is affected, like you see here. So parts of this glomerulus look pretty normal, but then other parts are really pink and sclerosed. Now, for years and years and years, the most common cause of nephrotic syndrome in adults in the U.S. was a disease called membranous nephropathy. And now, for whatever reason, that seems to not be the case anymore. C'est la vie. But it's still the most common cause of nephrosis in Caucasian adults. Now, I mentioned that lupus can cause lots of different renal lesions, and membranous nephropathy is one of them. The big thing to remember is that on biopsy, you're going to see thickening of the basement membrane. Membranous basement membrane. You're also going to have subepithelial immune deposits along the basement membrane. So here's our drawing, and the basement membrane is diffusely thickened. And then along the surface of the basement membrane, instead of being nice and smooth, it has these domes, which are the subepithelial immune deposits. And then in between the domes, there's so much thickening of the basement membrane that it pushes up between the domes and it looks like little spikes. So this is called a spike and dome appearance, and you should definitely recognize that. And here's what it looks like in the electron micrograph. You have a big, thick basement membrane, and you have the domes, which are the subepithelial immune deposits, and then the spikes in between. So remember, this is membranous nephropathy, so all these changes are clustered around the basement membrane. Next, I want to talk about membranoproliferative glomerulonephritis, or MPGN. Now, this can cause both a nephritic picture with hematuria, but it can also cause nephrosis and heavy proteinuria, just like we saw with diffuse proliferative GN from lupus. Now, this is membranoproliferative. So again, the basement membrane is involved, and it's also associated with cellular proliferation. But I like to use the word membranoproliferative to think about the basement membrane proliferating. So instead of just one single solid basement membrane, you actually see two basement membranes, which gives it a doubled up train track or tram track appearance. Now, on our drawing, we see some IgG immune complexes along the basement membranes. These are sometimes called subendothelial humps. Don't get that confused with the subepithelial humps that we saw with post-streptococcal glomerulonephritis or with the subepithelial domes we saw with membranous nephropathy. These are subendothelial humps. And then down here, the basement membrane has actually doubled up, and you see that tram track or train track appearance. And you can see the mesangium proliferating and invading the space between the two. There are also deposits in the mesangium, and the foot processes aren't normal. It's just like a bomb went off and everything's gone haywire. And here on electron microscopy, you can see the doubled up basement membrane at the top and that tram track appearance. And then toward the center, there are these dark immune deposits along the basement membrane and also in the mesangium. And I think it's worth knowing that MPGN can be caused by hepatitis B and by hepatitis C. So if they give you a patient with hepatitis B plus glomerulonephritis, think about MPGN. Lupus can cause MPGN, and then subacute bacterial endocarditis can also cause it. So again, hepatitis B, hepatitis C, lupus, and subacute bacterial endocarditis. Make sure you know those as causes of membranoproliferative glomerulonephritis. Now, like lupus, diabetes can do a lot of different kinds of damage to the kidney. So when the blood glucose is high, glucose gets tacked onto a lot of different things, like hemoglobin, that's what makes hemoglobin A1C. Glucose gets tacked onto blood vessels, and it gets tacked onto the glomerular basement membranes. So this is a non-enzymatic glycosylation, which just means you don't need an enzyme to tack the glucose onto things. But that glycosylation of the basement membrane makes the basement membrane thick, makes it dysfunctional. And you're also going to see non-enzymatic glycosylation of the arterioles, which causes the mesangium to proliferate. But diabetic nephropathy leads to proteinuria. That may begin as microscopic albuminuria, just a tiny bit of microscopic albumin in the urine, but it can certainly progress to nephrotic syndrome if you don't recognize it and treat it. So with diabetes, you might see thickening of the glomerular basement membrane, and then you can see these round acellular nodules within the glomeruli in the nodular type of diabetic nephropathy. And these are called Kimmel-Steele-Wilson nodules. That's something you should definitely know. And the mesangium can be dramatically expanded. So here, on light microscopy, there's this round pink acellular nodule, which is a Kimmel-Steele-Wilson nodule. Definitely be able to recognize that as a feature of diabetic nephropathy. And you also see how dense the mesangium is through here. Not a lot of cells, but a ton of that mesangial matrix. And the capillaries aren't nearly as prominent as they would be in a healthy glomerulus. Then the very last disease I want to mention just briefly is amyloidosis. Now, we've talked about amyloid before. Amyloidosis is a disease where you have these abnormal amyloid proteins that are deposited in various tissues, like in the kidney, and the heart, and the liver, the muscles, the brain. And all those amyloid fibrils just sort of bulk up the tissue. But in patients with systemic amyloid, the kidney is the most commonly involved organ. Now, in our drawing, you can see massive expansion of the mesangial matrix, kind of like you saw with diabetes, and then tons of these amyloid proteins that are deposited in the mesangium. But the test you need to remember for amyloid is the Congo red stain. Congo red stain will cause the amyloid protein to light up bright green under polarized light, and that's called apple green birefringence. Now, we've seen this slide before, and obviously this is not a renal biopsy, but I'm just showing it to you to remind you what apple green birefringence looks like with Congo red stain of amyloid. All right, we've gone through a ton of information, so let's have a go at the end of session quiz. All right, first question. What are the defining features of nephrotic syndrome? So the big one is proteinuria greater than 3.5 grams per day, and then also hypoalbuminemia and peripheral edema. Now, these patients also have hyperlipidemia and increased risk of infections and so on, but the three things that you must have in order to meet the criteria for nephrotic syndrome are heavy proteinuria greater than 3.5 grams per day, hypoalbuminemia, and peripheral edema. Next, glomerular histology reveals multiple mesangial nodules. So this lesion is indicative of what disease? Those are the Kimmel-Steele-Wilson nodules, which indicate diabetic nephropathy. Next, a teenager presents with episodes of gross hematuria and high-frequency hearing loss. What's the disease? So whenever you get kidney disease plus hearing loss, think about Alport syndrome. Can't see, can't pee, can't hear high C. All right, so the last question is very high yield. If you learn nothing else from this video, learn these high yield biopsy findings. So a linear pattern of IgG deposition on immunofluorescence, that's Goodpasture syndrome with those anti-glomerular basement membrane antibodies, anti-GBM antibodies. Lumpy, bumpy deposits of IgG, IgM, and C3 in the mesangium, that's post-streptococcal glomerulonephritis. Deposits of IgA in the mesangium is IgA nephropathy. Anti-GBM antibodies, hematuria, and hemoptysis, that's Goodpasture syndrome. Nephritis, deafness, and cataracts, that's Alport syndrome again. Crescent formation of the glomeruli would be rapidly progressive glomerulonephritis, also known as crescentic glomerulonephritis. Wire loop appearance on light microscopy would be lupus nephritis, so you remember the phrase wire lupus. Most common nephrotic syndrome in children, we said that was minimal change disease, no controversy there. Most common nephrotic syndrome in adults, I believe it's focal segmental glomerulosclerosis. Kimmel-Steele-Wilson lesions, or nodular glomerulosclerosis, again that's diabetic nephropathy. Electron microscopy shows effacement of the epithelial foot processes. That's going to be minimal change disease. Nephrotic syndrome associated with hepatitis B is membranoproliferative glomerulonephritis, or MPGN. Nephrotic syndrome associated with HIV is focal segmental glomerulosclerosis, or FSGS. Electron microscopy shows subendothelial humps and a tram track appearance. That's membranoproliferative glomerulonephritis, or MPGN. Remember, membranoproliferative sounds like the membrane is proliferating. It means it's doubled up and it looks like train tracks. Light microscopy shows segmental sclerosis and hyalinosis. That's focal segmental glomerulosclerosis. Purpura on the back of the arms and legs, abdominal pain, and IgA nephropathy. That's Henoch-Schönlein purpura. Apple green birefringence with Congo red stain under polarized light is amyloidosis. Electron microscopy shows spiking of the glomerular basement membrane due to electron-dense subepithelial deposits. That's membranous nephropathy. Remember that spike and dome appearance. So if you don't know those, make some flashcards. Make sure you know those buzzwords. Then finally, we have two rapid-fire facts. Nodular hyaline deposits in the glomeruli, those are those Kimmel-Steele-Wilson nodules, again, which we said are seen in diabetic nephropathy. And then glomerulonephritis plus pulmonary vasculitis. So the two things that affect both the kidneys and the lungs are granulomatosis with polyangiitis and Goodpasture syndrome. All right, great work. I'll see you next time.
Uh-oh, guess what day it is? Guess what day it is? Huh? Anybody? Bladder, hey, guess what day it is? Aw, come on, I know you can hear me. Heart. What day is it, heart? Liver, guess what today is?
It's hump day.
Woot woot!
Dr. Lewis, how happy are folks who study for the boards using Doctors in Training USMLE review courses?
I'd say happier than a kidney with acute post-streptococcal glomerulonephritis on Wednesday. You know, because of the subepithelial humps.
Hump day! Yeah!
Doctors in training. Structured, focused, awesome.